So I've been asked to speak on cross-linking on a cornea post-LASIK ectasia. Should we be doing things differently? I was trying to, search literature, and there is nothing, so different about it. Whatever Dr. Amit and Dr. Chintan has talked about, depending on the thickness, we follow the same protocol, and probably the effect of cross-linking is a little less in post-LASIK eyes. The reason for that, I'll come to that later on. But basically, there is no difference in way we approach the eye with the post-LASIK ectasia, and this is the definition for what has been given by the corneal ectasia after LASIK. There should be a minimum inferior topographic stiffening of 5 diopter or more compared with the immediate postoperative appearance, and there should be loss of 2 or more lines on snarl visual acuity, and the change of manifest reflection should be 2 diopter or more, either sphere or cylinder. And as we all know, the management option are many. First and the foremost is contact lens. And to stabilize the progression of the disease, C3R is the choice of treatment, which could be combined with intracorneal weakness segments, or maybe with PRK to regularize or correct some degree of refraction. And the last resort, when nothing works, is corneal transplantation. And post-laser in situ keratomycosis, current understanding, these are the various risk factors which can lead to post-LASIK ectasia in the paper by Rendelmet et al. In 2006. And the incidence is not very high, and the risk factor they recognize are, one is the younger age group, high myopia, or when the residual beds was less than 250 micron, or preoperative central corneal thickness less than 500 micron, or where the keratometry is more than 47 diopter, and especially with against the rule astigmatism, and patient with subclinical or formless keratoconus, and probably trauma related to excessive eye rubbing. And of course, as already Amit has highlighted, pregnancy, post-LASIK pregnancy can sometimes induce ectasia because of hormone changes which happens in the body during the second and third trimester of pregnancy. And I will discuss one case. Again, this is case from Dr. Chintan's clinic. She's a 30-year-old female teacher who had progressive diminution of vision for last 2 years, and she had undergone LASIK for 8 to 9 diopters of myopia in 2003, was spectacle free for about an year, and started having again diminution of vision in both eyes during pregnancy, and presented to us her clinic in 2012 with the visual acuity of 6 by 6 in the right eye and a refractive error of 5.5 myopia, and -7 with a very high cylinder in the left eye with the best acuity of 6 by 36. And on clinical examination, gross examination, you don't see anything grossly, and on a slit examination, you don't see any evidence of cataract. So the possible diagnosis she put together was, it could be either post-LASIK ectasia or a regression, or it could be because of nuclear cataract, or it could be axial myopia. This is the topography of the two eye. On the right side, you can see there are hardly any anterior elevation, and the K readings are fairly normal. In the left eye, we have inferior temporal steepening with the maximum K reading of 53.7, and on the Bailey-Numbers map, you can see a posterior elevation in the left eye. So a diagnosis of post-LASIK ectasia was made in the left eye, and a long-term regression in the right eye. And how we differentiate between the two is, there is no loss of best corrected visual acuity in the long-term regression. Wherever there is a loss of this best corrected visual acuity in LASIK ectasia, and there is a progressive steepening and thinning of the cornea, which is absent in long-term regression. And so we did a C3R in the left eye, and the right eye was kept under observation and prescribed glasses. This is the preoperative K reading, and after the C3R, there was a flattening of around 2.3 diopter in this eye after 28 months, almost 2.5 years. And this is a final reflection after the C3R, and she improved to 6.9. There was a drastic decrease in the cylinder, as you can see in this case. And so just to emphasize, there is hardly any different protocol in post-LASIK eye, though one study do say that we can lift a flap for around 2 to 3 millimeter and inject the dye within the pocket and do the cross-linking for a shorter duration, but the results were not so promising. Only thing in these cases to be careful is if we are doing a epithelial off cross-linking, we should try to avoid removing the epithelium at the flap junction, because sometimes there could be a once you are stroking the epithelium, there could be a risk of flap coming off, or later on there could be a little contraction of the flap, or there could be a risk of epithelial growth following post-LASIK C3R in these cases. But if you are doing in thin corneas, contact lens assisted or transepithelial, then that risk is much. And this is one of the largest studies published in uh, on cross-linking in post-LASIK eye. They included this recent study published in 2017 by Peter Hirsch et al. They include almost 179 patients with post-LASIK activity and divided into two groups: CXL group, the standard protocol group, a Dresden protocol they followed, and the other group they didn't give any treatment at all. And in the results, they could found that more than 2 diopter in almost 18% of the cases and increased by 2 diopter in 4%. So even after the treatment, there was an increased progression of the disease. And in treatment group, almost 32%, one third of the eyes gained 2 line of best corrected visual acuity, while these 4% of the eyes which had increase in refraction, they lost more than 2 lines. And the conclusion of the study was that corneal collagen cross-linking was effective in improving the maximum K value, corrected distant acuity, and uncorrected distant visual acuity in eyes with corneal ectasia 1 year after treatment with an excellent safety profile. This is just in graphic form. They have shown that almost 40 patients had a decrease in K rating from almost by 1 diopter, and gradually the K rating, the average decrease in K was 2.6 diopter in combined cases. And in another study, post-LASIK eye, they have shown that the post-LASIK ectasia, the CXL, C3R, stabilize the cornea as the progression of the disease is concerned, and there was an improvement in visual acuity in these cases. And in another study, they found that the most of the patients who are likely to benefit by C3R in post-LASIK eyes where the pre-operative, before doing C3R in these post-LASIK where the visual acuity was better and the Kmax
Screen
was less
share.
than.
Where is the screen share option? Which one? This one. Share screen. Okay. वहाँ से
Okay,
आएगा.
this is the last slide on this. Is it visible?
The time way.
But we have
Yeah.
downloaded the presentation first on the laptop.
उसमें सारे videos हैं. I can't do it
Is
directly.
it?
I'm sorry, the people who are looking after the coordination of this hall, we can hear other voices.
Okay,
Inasha?
all right. So I thought something is wrong. Okay, and then this study by Peter Hirsch et al. They showed that keratoconus patient showed more improvement in topographic measure as compared to the eyes with post-LASIK ectasia. And the reason they postulated that the biomechanical difference caused by the LASIK flap, because the LASIK flap doesn't add to the biomechanical strength of the cornea, and the possible difference in the riboflavin diffusion rate in the post-LASIK cornea, especially in the interface, may make a difference. And there could be, as we know, these post-LASIK ectasia patients are cornea collagen is maybe little different. So the intrinsic pathophysiological differences between keratoconus, keratoconus and post-LASIK ectasia eyes may be making a difference as far as the recovery is concerned. So basically speaking, there is a practically no difference in the way we do C3R. We follow the same guideline as you will follow with the thin cornea or with the normal corneal thickness, but probably the result may not be as good in post-LASIK eye as in the virgin